Welcome to This Week in Medicine. It's April 4th, 2022. And like Lloyd Bridges in the movie Airplane, looks like I picked the wrong week to give up doing This Week in Medicine. Carrie did a great job on nutrition last week, but I think based on all the emails I had from you this week, it would have been a good idea to discuss Omicron BA2 last week. So without further ado, let's go back to COVID. Again, the Foxhound Foundation has an educational mission. We were supposed to be talking today at a national conference, but that conference went virtual, likely in part due to Omicron BA2, which is high in our region. Again, Dr. Yamamoto, as part of the Foxhound Foundation, does educational talks, but again, we're virtual. Current foundation initiatives are our wellness center, our nutritionist Carrie, who's doing an awesome job, our Active Masters program, a program we have for patients with Parkinson's and movement disorder, and hopefully some new classes. I'm looking for yoga instructors, other kinds of movement specialty programs, aiming for probably Tuesday and Thursday mornings. So if you're interested, let me know. This is our wellness center. So what came into the inbox this week? When can I get a fourth shot? We'll talk about that. And apparently, most of Northwest DC is going to France in April and May. So this was in my inbox all over the place. Also, a story from a woman who sat across from someone from London. Found out a couple days later that person had Omicron. They were at a dinner together, and she got Omicron infection. And then, of course, if you get Omicron infection, the next email to come into the inbox is, should I take Paxlovid? Questions about Omicron BA2, which is definitely here in our area. To mask or not to mask? Well, if you don't want to get Omicron BA2, put a mask on. Should you get a fourth shot before you travel? Almost as common as I'm going to France. Do I need a fourth shot? And it's Irritable Bowel Syndrome Awareness Month, which we will likely discuss in future talks. So because the inbox was so full this week, I have a second slide of the inbox, which was basically variations on the theme of when do I get my booster shot? Do I need a fourth shot? Should I get my fourth shot now? When should I get it? Should I get a booster shot now? Do I even need a fourth shot? Should I get a booster shot now? It's been more than 4 months. So let's answer all of these inbox questions. Unfortunately or fortunately, depending on your perspective, I think the answer to all of these questions in the bubble is that the answer needs to be individualized. One size probably does not fit all. So a fourth COVID mRNA shot, there was a research article, as I mentioned last time, in the New England Journal of Medicine in healthcare workers. These healthcare workers were not over 65 years old. But the study did show, and again, this is peer-reviewed because it was in the New England Journal of Medicine, that giving a fourth shot, or what we would call the second booster of an mRNA vaccine, did not provide additional benefit in terms of decreased hospitalization and death from COVID. The FDA did approve a shot for people over 50 if they are 4 months from their booster shot or third shot. That was approved this past week. The question is, do we have enough immunity from our huge spike of December and January Omicron infections that first Omicron immunity would prevent Omicron BA2 now? And we might. So far, I have not seen a case of someone who had Omicron in November or December and is having Omicron infection now, which presumably would be BA2 variant because that is the leading variant in the country. It took over from Omicron variant that we had in November and December. So 2 different viruses. You should have probably 90 days worth of immunity if you had the infection in November and December. So you should be immune from BA2 if you had infection in November and December. And quite frankly, that infection in November and December does act like a short-term boost to your immune system. Again, I've been checking antibody levels in patients who aren't sure they want to do their booster right now, and everyone who had a booster last year in 2021 still has high antibody levels. No one has 0 antibody levels, so I'm not sure where the data is that says that they don't. And remember, after antibody levels decrease, T cell immunity does substantially take over in helping prevent infection. Might these original COVID vaccines not induce good immunity against Omicron? Yeah, we don't think so, because you can still get Omicron infection despite the booster. So it certainly prevents death and hospitalization, which are very important endpoints, but it may not prevent Omicron infection. Remember, this Israeli study is not peer-reviewed. There was a 78% improvement in survivability over the protection you got from the third shot. So it sounds like a lot, but you have to look at the hard numbers to see that this probably doesn't demonstrate as much of an increase as we think. And then what's a better booster? Getting your fourth COVID-19 vaccine? Remember, this is a virus that probably doesn't exist anymore. It's mutated so much. Or should we get a booster that's specific to what's circulating now, which is Omicron? And that's similar to the way that we do flu shots. So these are all very important questions, and I'm not going to tell you I have all the answers. So the second Omicron wave is here. It's BA2. Stool studies from the Northeast were able to predict this a couple of weeks ago. Again, these are sewage studies, but they are very helpful. I think the first cases in our area started to surge around March 26, and that was in our area where I saw cases start. Patients have been taking Paxlovid. It is available. Paxlovid really wasn't widely available in November, December, and January. It was approved in December, but it wasn't easily available, and it was mostly released to pharmacies in low-income areas and places where patients were sicker demographically and didn't have options for hospitalization or medical care. So that availability of Paxlovid has expanded. I don't think anyone is sicker than the initial Omicron infections in November and December. The people who've had BA2 for the past 2 weeks basically have the same symptoms as people from November and December. I think that some of the people who have gotten Paxlovid in the past 2 weeks have turned antigen tests negative as early as day 4. So indeed, Paxlovid may help us contain and prevent replication of the Omicron virus, which is what it's supposed to do, and therefore make people less contagious. So Omicron wastewater surveillance is very important. It's a great tool. The Broad Institute is an institute that's a combination of specialists and researchers from MIT and Harvard. They do pathogen genomic surveillance. So they're looking at the gene patterns in the wastewater surveillance sites to tell us when there is an uptick in certain pathogens. Specifically, there was an increase in BA2 3 weeks ago in the Boston area and the Northeast. And that precedes the clinical outbreaks, because when they see this increasing in the sewage, that means it's circulating and soon will be spreading to people. So the Broad Institute serves this area of the United States. Again, they do viral sequencing there. Thank goodness they do. They are supported by the CDC. And again, they're a partnership of MIT and Harvard. You can see the weekly samples that they have sequenced. Here's March 2022. And they're telling you that they can tell which COVID-19 variety is on the increase and can predict outbreaks a couple of weeks ahead of time. So this is a great graphic. You can see here's Delta infection. Remember how we talked about Omicron may wipe out Delta infection? Well, there's Delta in January of 2022. We've been told that Omicron BA2 specifically, is now the leading viral sequence. You can look even back here when we had many more in May of 2021, viruses that were all competing for our attention. Now with increased infectivity, and BA2 is probably 30% more contagious, we can see that individual species are winning out. The battle was here for who was going to win, and clearly here we can see Delta, and then Omicron is leading the pack. And again, they're able to predict that BA2 was about to spread. So Paxlovid to the rescue. Paxlovid is actually 2 medications. It's taken twice a day for 5 days. One is a protease inhibitor that stops viral replication. Another is a protease inhibitor that boosts the nirmatrelvir. So ritonavir and nirmatrelvir are both basically antiviral pills that developed out of the research for HIV, specifically ritonavir. Ritonavir, as a protease inhibitor, increases the lifespan of this drug in your system, which allows you to inhibit replication of the COVID virus. You take 2 tablets of nirmatrelvir and 1 tablet of ritonavir. You can't take this if you have kidney and liver. This should say liver failure. So if you're on dialysis or if you are close to needing a liver transplant, you can't take this medication. It has many drug interactions, and furthermore, you can't take it to Paris. Again, remember, there are a lot of messages in my inbox. Virtually all areas of DC and Bethesda apparently are going to be going to Paris for April, May, and June, and you cannot take Paxlovid with you on the plane. The reason being that this is tightly federally regulated, and right now the FDA indication is that you have to have a positive COVID test in order to even be prescribed Paxlovid, which is being provided for free by the federal government. So you can't take it with you. This creates problems. Paxlovid was approved December 22nd, 2021. So obviously it's been around for a couple of months, but it hasn't been widely accessible until basically this Omicron BA2 surge. It is indicated again for the mild to moderate treatment of coronavirus disease in adults, pediatric patients 12 years of age and older, but you have to have, as you see here, a positive result on COVID testing. So you have to be positive. You can't just call the doctor's office and ask for a prescription of Paxlovid. The indication is you actually need to have a positive test result. And this really is for people at high risk for progression to severe COVID illness, including hospitalization or death. So if you have a mild case where you have a runny nose and a cough and you don't feel terribly ill, Paxlovid isn't indicated for you. It's really indicated for people who have risk of hospitalization or death. It should be initiated within 5 days of symptom onset. And from the patients I prescribed it for in the past 2 weeks, it does seem to make a difference for them. And we definitely prescribed it within 5 days of onset of the illness. Again, this was December 22nd, and we're finally seeing, I think, effective rollout of this antiviral, and I do think it's helping people. The problem is Paxlovid drug interactions. There are many interactions, including, but not limited to, certain statins, so simvastatin, some of the other statin medications, and quite frankly, because we don't have all the data, because this is a brand new drug, the ritonavir isn't new, but the other portion of the drug, the other protease inhibitor, is quite new. I think it's only about 2 years old. So I think for safety, I'm just telling patients to stop their statin for 5 days while they take Paxlovid. It also interferes with Xarelto and Eliquis, but not Pradaxa. So there are people who really need to have an individualized approach to this. Some patients have a very high risk of going off their blood thinner. That's what a DOAC is, direct oral anticoagulant. So you have to talk about this with a doctor who knows you. It may not be safe for you, especially if you have mild symptoms. Why go off your blood thinner if you have mild symptoms of Omicron? It may not make sense to take Paxlovid for you. Some ritonavir interactions. It does interact with some selective serotonin reuptake inhibitors, so antidepressants like Zoloft. It can increase their blood level, and it could inactivate birth control pills by decreasing estrogen levels. And there is a long list of other interactions. So that brings into question the test to treat idea. Test to treat is something that was discussed. This is actually a very good article. I believe this was NPR. You can read it, not just listen to it. But it talks about the problems with test to treat and what test to treat is, which was a plan announced at the State of the Union address. We'll go over that in some detail. So at the State of the Union, it was discussed that we're launching the Test to Treat initiative so people can get tested at a pharmacy, and if they are positive for COVID, receive antiviral pills on the spot at no cost. And the question and the problem with this is the on the spot, not so much the no cost, it's really the on the spot. This is very problematic and maybe wasn't well thought through. The problem is that COVID pills come with these prescribing challenges. Pharmacists say they're well qualified to handle these prescribing challenges, and they may be. They have computer programs that will look up drug interactions, so when they put in Paxlovid and they see that you're on a statin or a blood thinner, they'll know that that's an interaction. But do they know you? Do they know how important your blood thinner is to you or some of these other medications? I would say no. They admit that they've been managing drug interactions and dose adjustments for decades, and that is true. Pharmacists do this, but they don't know the clinical side of it. They don't know the individual patient. High-risk patients who need Paxlovid, people who might get sicker and need hospitalization because they're sick with COVID, those patients who need Paxlovid probably also have high-risk medications. They go hand in hand. If you're sick and you might need hospitalization for Omicron infection, therefore you need Paxlovid, you may also have medical conditions that your own personal doctor needs to review. So it really must be prescribed. You can't just test and pick up the box without a prescription. They were rolling this out in 10% of the 10,000 CVSs where they have minute clinics. So they proposed that 10% of those can do this, which is still a pretty small number. But do we really want them doing that? Do you want your pharmacist telling you how important your medications are relative to your clinical conditions? Who's making prescribing decisions? So the AMA made a statement on test to treat, and I think they are right on the mark. They said that they are protesting the pharmacy-based clinic component of test to treat, and I agree with that. They say that there are safety risks and significant possible negative health outcomes because it oversimplifies the issue of how important certain medications are to a particular patient and the interaction with Paxlovid. It omits knowledge of the patient's medical history. I know your medical history, your personal doctor knows your medical history, and the complexity of these drug interactions, and who's going to handle negative reactions to this combination of medication. It has 6 pages of drug interactions. Trust me, this week I went through the drug interactions on Paxlovid for every patient I prescribed it to because I had to ask them to hold or change or reduce the doses of medication. This can even apply to over-the-counter medications like St. John's wort. So you need to have a doctor who knows what you're taking. And please, if you do get a Paxlovid prescription, even tell your doctor your over-the-counter herbal supplements, things that are not prescription, because those can also interact. The long and short of it is that the AMA says that this idea of test to treat, which is test in a pharmacy, get your positive test result, and then have a pharmacist write you a prescription at a minute clinic, is extremely risky. And I agree, this is entirely risky. So if you think that you would like to take Paxlovid, you really need to talk with your doctor about it. Tony's tip of the week, please read your forms before you send us the forms to fill out. Summer school forms might require vaccination dates, or they might require an actual physical exam within 6 months. This is about the time when people are applying to summer camps and summer programs. If you're a new patient in our practice, we might not have your vaccination forms from 10 years ago from your pediatrician office. So make sure you review the form so that we know what we have to fill out. Long-term care insurance forms might require data on your ability to do ADLs, which are activities of daily living. I can't answer that question. I don't know if you're able to bathe, feed yourself, if you need assistance in any of those things, grocery shopping. So let us know what your abilities are so we can fill out these forms. Otherwise, it will delay the processing of your form. Nursing home forms often require a TB test, and that can either be a skin test or a blood test. So review your form because the TB skin test, called the PPD, takes 2 days. So you won't get your form back until we get that test result. School volunteer forms often do require, especially in the District of Columbia, a TB test. Again, that can be a blood test or a skin test. So fast pitch, timing of a booster is an individual decision. If you don't want to do your booster now and you want to wait until there's a more specific booster, let your doctor know. If you have a suppressed immune system, it's probably a good idea to do your booster now. But as you've heard from likely experts in the media, infectious disease experts, virologists, Even though this has been approved by FDA, it's still an individual decision. We're not recommending that everyone across the board get a fourth booster shot or a fourth shot, second booster shot. This is really something that's up to the individual. And quite frankly, some individuals still have such a high antibody level from their third shot or first booster. It makes you wonder why this is being recommended right now. You may not need it. Again, it's an individual decision. Use your judgment. There's more to protection against these viruses than just your antibody level. The immune system is much more complex than that, and these vaccines are very powerful. So you might not want the booster now. Give yourself the benefit of some thought. But again, many people are traveling abroad in April and May. Will the booster prevent you from getting an infection in Europe? Maybe not. Will it decrease the severity of your illness? Maybe. Some people still do need to mask, so remember, if someone's wearing a mask, it might be because they're on chemotherapy and don't want to tell you. It might be because they are already exposed and don't want to tell you they were just exposed to Omicron and don't know if they're sick yet. The number of possible reasons for people to wear a mask is vast, so we all need to respect each other's choices. Masks can prevent infection, but a booster may not. So remember that just because you get the booster doesn't necessarily mean you won't still get the infection. Again, remember your health pyramid is incredibly helpful. In particular, diabetes has been shown to be a significant risk factor for doing poorly with COVID and Omicron infection. That's from data from the past couple of days, that diabetes in particular really is a predictor for poor outcome with COVID. So you want to know all of these aspects of your health pyramid and make sure that they are firm, not just in terms of Omicron, which we seem to talk about a lot, but in terms of your survival from any illness, whether it be other infection like bacterial infection or heart disease. In particular, heart disease. We still have our book, You Can Prevent a Stroke. And remember, this isn't just a disease, this is natural aging. So we are all susceptible to the aging of our cardiovascular system. And you can plan for your future with our book. Please subscribe and hit like. If you have a Google account, that's how this works. Thank you for your attention. And